Good morning, dear colleagues. I would like to thank you for joining us here today. I hope that you are all in good health and good shape. On behalf of the mission of Israel to the World Trade Organization, it is my pleasure to welcome you. I would like to tell you that we are here today about more than 80 people representing delegations to the UN, to the World Trade Organizations, secretariats of international organizations such as the WTO, World Health Organization, and some other UN organizations. So, as some of you know already, the mission of Israel has been organizing these lectures for a couple of years by now. It is an initiative of my colleague Rodolfo, who is with us here today. We felt that now, perhaps even more before, it is important to engage in a thought-provoking conversation that fosters dialogue. While this is, in fact, the 12th session in this initiative, it is our first virtual one. So please, before beginning, allow me to first orient you to our agenda. After my brief introduction, Professor Shashua will present for about 30 minutes. I'd like to ask you to please reserve your questions and comments until the end of his presentation. In order to ensure that we can get as many questions as possible, I'd like to ask you to please send your questions to my colleague Rodolfo through the chat available in the Zoom platform. Alternatively, you can indicate your desire to raise a question by virtually raising your hand, and we will address them in a first-come, first-served basis. So with that out of the way, let me introduce you to our guest speaker today, Professor Amnon Shashua. He is a professor of computer science at the Hebrew University in Jerusalem and co-founder and CEO of Mobileye, an Intel company. Professor Shashua will be delivering a timely lecture entitled Exit Strategies to Restart the Economy Following the Population-Wide COVID-19 Quarantine. This lecture will address questions that we have been wondering about in the last few weeks, namely how to approach the next step in the pandemic, or perhaps more precisely, how can we restart trade and economic recovery and balance the well-being of the global economy without overwhelming the capacity of our health systems and spiking mortality rates. We couldn't think of a better speaker on this topic than Professor Shashua. The list of his achievements is really long, but just to highlight a few. He was awarded the Dan David Prize in 2020 for his groundbreaking work in artificial intelligence. He is a co-founder of Mobileye, a company that claimed in 2014 the title for the largest Israeli IPO ever, and in 2017 became an Intel company in the largest Israeli acquisition deal ever for a total of more than $15 billion. He has delivered talks based on some of the ideas that he will be presenting here today to different audiences in the last few weeks, such as the academic institution of MIT in Boston, and also to the Israeli parliament, the Israeli Knesset. Last but not least, I wish to repeat a reservation that we make before any of the lectures that we sponsor under this initiative. The views expressed today by Professor Shashua do not necessarily represent the views of the government of Israel, nor of the mission of Israel to the WTO. Our goal is to provide a platform to hear views of remarkable individuals that engage in research and knowledge creation in issues that are of great interest to the WTO delegations and to those who are involved in shaping the international trade policymaking. So I will stop here, and without further ado, Professor Shashua, the floor is yours. Thank you.
From the beginning. So the COVID-19 pandemic has the potential of turning out to one of the biggest financial crises of our time. Therefore, it is very important to come up with ideas that are backed by science, backed by data, how we take the next step. Many countries began with a lockdown period. And now, after a period of a month or 2 months, lots of data has been accumulated in each country, and the ideas of how to take the next step and how to prevent the next outburst are now, it's timely to come up with those ideas. So 2 weeks ago, my colleague and I, Shai Shalev-Schwartz, we looked at the data and had some observations, and then we used computer science techniques to come up with some insights that one can prove. I'll of course not go into the heavy mathematics. I'll do some back of the envelope calculations to make the point of what we're proposing to do. And I think it's also very important that this thing is treated on a global in a global way, because if one country solves the problem and other countries do not, and because trade is global, it doesn't help us. We need to find solutions that can be adopted by many countries in the world, so that we can simultaneously start rejuvenating the economy and restarting trade. So the question of interest is that we looked at the available resources of mitigating the pandemic, and we see that the resources are divided into two. One are unlimited and available resources like social distancing guidelines, hygiene guidelines, facial masks. These things help to slow down the outburst. They help to slow down the spread. They will not stop it, but they'll slow it down. So this is one set of resources that one has. The second set of resources are limited in nature and also expensive, and these are testing. You know, to do many thousands or many tens of thousands of testing a day, and also do it in a short response time. So if someone complains that they have symptoms, the testing should be done immediately in a very short time, and then using contact tracing technologies to find out the first circle of people around that person and even the second circle of people, and then isolate all of them for at least 2 weeks, and then do a pandemic epidemiological investigation. So these resources are naturally limited and expensive, and one can also try to analyze their effectiveness if they are applied population-wide. So those are the two tools available if one does not want to continue with the lockdown. Of course, if one continues with the lockdown, the pandemic will be under control, but then the economy would suffer considerably. So when we're thinking about non-quarantine methods, those are the resources that are available. Next slide, please. So when we looked at the question of interest, the default approach in many countries is to apply those limited resources across the entire population. So the idea is that one exits from the lockdown, and now we go over tens of thousands of tests, PCR tests a day, identify all the people that are infected, and isolate them and all those around them using contact tracing. And there are many studies that are showing that you can really flatten the curve. You can reduce the daily increase of the spread using the contact tracing techniques and slow down the outburst, and in that way control until the vaccine arrives. Now, the possible issue here is that if you have a leakage, that means you didn't find all the people that are infected, and you have now a runaway, which is a leakage, we can return to an exponential growth of the virus, and then we have to do another lockdown, and then we'll go from lockdown to lockdown, and then the economy will suffer greatly. And the reason that there could be a leakage is that there are two issues. One issue is the asymptotic people who are infected but have no symptoms. The belief is that this could be up to 50%. So for everyone that is infected, there is another infected person that has no symptoms and will not have any symptoms. So when you think about this containment policy of identifying people and isolating them and all their people that were around them, half of the people will run away from you because they're asymptomatic. So this is one issue. The second issue is cooperation. One can reasonably assume that as you proceed over time, more and more people, especially the low-risk people, would seize a cooperation with this technique, because once you report that you have symptoms and you're identified as corona positive, they'll isolate you, isolate the people around you. If you have a small business, they may shut down your business for about 2 weeks. And if you are a young person, you may tell yourself, well, I'm not at risk. Why I'm cooperating with this? So this will add to the number of people that run away, and this could result in a leakage. So when we think about the available resources, applying all those resources homogeneously, uniformly over the entire population may cause significant leakage, and we again return to the exponential growth, and we have to get into a lockdown again. So next slide, please. So the question that we ask is how do we properly allocate those resources, both the limited and unlimited, in the way that we can guarantee that we control the virus spread and restart the economy. Okay, so we're not saying that let's not use those techniques, but let's use those resources in a way that is more focused, that will have a much higher chance to succeed. Next slide, please. So the first observation, when we look at, for example, data from Israel, when I look at the left side of this slide, when you look at the people in the critical ICU beds that require respiratory systems, the number of people from that group that are below the age of 65 and have no precondition, no pre-existing conditions like blood pressure, diabetes, cardiological issues, that number is quite small. In Israel, it's about 16%. So a few days ago, there were about 116 people in critical ICU beds, and there were 119, and 16 of them, only 16 of them, were from this low-risk group, people below 65 without pre-existing conditions. When you look at what are those pre-existing conditions over the entire group, over the 119 people, you see that the blood pressure is about 30%. Next is diabetes, about 30%, and then cardiological issues, about 10%. And then there's a long tail of additional conditions. By the way, when you look at data from other countries, there's a big variability. For example, in Italy, blood pressure accounts for about 50% of the people in critical ICU beds. In the US, it's less than 20%. So this needs to be investigated in each country separately. When you look at this number, you ask yourself, well, maybe the issue with the low-risk population is not as bad. Maybe we can afford leakage in the low-risk population and put all our resources on the high-risk population. But in order to do so, we need to do some calculations. So the next slide, please. So the model that we propose here is that we use the limited resource and focus them on the vulnerable population, the high-risk population, people above 65 or young people with pre-existing conditions. And then we release the low-risk population, but under the slow spread, means under social distancing, facial masks, hygiene rules, such that there will be a spread, there will be exponential spread, but a slow exponential spread. And then I'll be more specific about it in the next few slides. And then put all our resources of containment on the high-risk population. So the high-risk population and people that serve the high-risk population. So if you have caregivers that are from the low-risk population that are working to provide care to the high-risk population, those people need to be tested daily. And if they have symptoms, then them and the people around them should be self-isolated. So focus all your resources on the high-risk population. And the high-risk population will be much more cooperative because they know that they're at high risk. they know that if they catch the virus, if they are infected, the risk of mortality, the risk of morbidity, of requiring a critical ICU bed is not negligible, it's quite high. So they'll be much more cooperative than if you apply those techniques over the entire population. And then, of course, the low-risk population, since in this case it's the young people, the economy would not be severely affected because they can go back to work. And I'll be more specific about it in a moment. Next slide, please. So the idea, and this is where the mathematics come in, is to say, well, if I release the low-risk population under some certain spread, again, any spread is exponential, under a certain spread, what would be the maximum, what would be the upper bound of the number of critical ICU beds that I need to prepare in order to contain the outburst? Because one of the big issues of this pandemic is that it could overflow the health system. Too many people require simultaneously critical ICU beds, and as we saw in Italy, and somewhat of it in Spain, that it overflows the health system, and that creates a much higher mortality rate than necessary for the virus itself. So the idea is that, can you calculate an upper bound on the number of critical beds, given that you release the low-risk population back to work, back to social and economical activity? And it turns out that you can do what I'm going to show here is a back of the envelope calculation. But in the academic paper, there is a formal study using concentration bounds on order to put the necessary bounds from a theoretical perspective to bound the number of critical beds. But what I'm going to show next is only a back of the envelope calculation, but I think it's sufficiently compelling to understand, to appreciate the concept. Next slide, please. So this slide is really the critical slide. So if we look, so we are now talking about releasing the low-risk population. So in Israel, for example, the low-risk population, so Israel is a country that has 9 million inhabitants. About 1 million are above the age of 65. And let's say another 1 million are people with pre-existing conditions, like blood pressure, diabetes, and so forth. So we're left with a population of 7 million people. And let's assume we release them, but under social distancing rules, both at workplace, both outside of work, with facial masks, social distancing, and hygiene guidelines. So we are talking about a spread, and let's assume that this spread has an R effective of 1.4. So R effective is the number of people you infect on average in a day. So if you are infected, R effective of 1.4 means that you will infect 1.4 people on average on a daily basis. So of course, this is an exponential growth, but it's a slow exponential growth. Why did we take 1.4? Because if you look at research from China, in terms of what is R effective of the coronavirus, it varies from 1.4 to 3.8. So 1.4 is in the lower spectrum of the expansion, and we believe that this lower spectrum is justified because we will be releasing people under social distancing guidelines. So again, we're talking not about a lockdown, we're talking about an exponential spread. So now if we look at the calculation of what is the maximum amount of critical beds that we'll need, that there are three factors that are going into it. One is the size of the population. So in Israel, it's 7 million. One is the percentage of being infected. We'll get to it in a moment. And the other one is what is the probability that you would require a critical bed if you are infected. Now, if you look at the right-hand side on the graph, this is taking the epidemiological models. It's a set of differential equations. It's called SEIR. And you apply the data that we know today about the virus. For example, what is the incubation time? It's around 5 days. What is the infectious time? It's about 2.9 days. So all the data that is publicly available about the dynamics of the disease. And you plug it into those, into the model, the differential equations. And what you see in the graph, that if you put R effective of 1.4, you would see that the middle graph shows that at the peak, we'll have 6.7% of the population infected. Okay, and the integral would be 29%, and that's what's called the herd immunity threshold. Okay? So if we assume that spread, it's still exponential. It's a slow exponential, and at the peak of it, it will be 6.7% infected. So this gives us the middle number. We said we need size of population, percentage of infected. So percentage of infected at the peak would be 6.7%. And what we need now to figure out what is the probability of requiring a critical bed given that you're infected. Next slide, please. So here we look at available data, and we take some worst case assumptions. So in Israel, a few days ago, there were 19 people from the low-risk population that require critical beds. And as I said before, out of 116. But what we're interested here is the number 19. Now, we need to figure out if we go 10 days earlier than that, because from the time you are infected until you require a critical bed, it's about 10 days. So we need to go back in time 10 days and ask how many people in the population were infected. So in Israel, 10 days before that, there were 5,000 people infected. But those 5,000 people is a lower bound because those 5,000 people were tested. So it's not the true positives, it is those that were tested. And now the question is, what is the true number of people that were infected at that date? Now, nobody knows. One can take a lower bound that it's twice as that. Why is that? Because the belief is that at least 50% of people are asymptomatic, they have no symptoms. So for anyone that you tested is positive because that person had symptoms, there is another one that had no symptoms. So a lower bound would be twice as that. If we look at Austria did a survey, a random survey about a week ago. And they came with the conclusion that the number of true positives is somewhere between twice to 5 times the number of people that are tested. Okay, so of course, if we do a random sampling in Israel, we can get that number accurately. But let's take the worst case, and the worst case, let's assume it's only twice. So let's take there were 5,000 people multiplied by 2, it's 10,000. Now let's remove from that about 15% of them were above the age of 65, and then about 10% are pre-existing conditions. So we remove 25%, and we're left with 7,500. So now we divide 19 by 7,500, and we get bound on the probability of requiring an ICU bed if you are infected. So it's 0.25%, and this is really an upper bound. It could be much lower than that, because there are people who believe that the number of true positives is at least 4 times the number of people that are being tested. Okay, so now we have all the numbers available. We have the probability to require a critical bed multiplied by the percentage of the population being infected at the peak of the outburst, which is 6.7%, and multiplied by the size of the population, of the low-risk population in Israel at 7 million, we get to about 1,200 critical beds. So just to calibrate that to a critical bed per 100,000 inhabitants, it's about 11 beds or about 12 beds per 100,000 people. Okay? So this is a number that, from an Israeli perspective, is already available. Israel has already about 3,000 critical beds waiting to contain the pandemic. Okay? If you look at the number of critical beds in various countries, the US has about 33 critical beds per 100,000. United Kingdom has 6. So these numbers are quite reasonable. So you need to prepare 12 critical beds per 100,000 inhabitants. And this gives you an upper bound on the number of beds that you need to prepare. But now you can ask yourself, okay, what is the sensitivity to leakage? Let's assume that I release the population with a R effective, assuming an R effective of 1.4, but it's actually 1.5 because people don't obey the social distancing rules and so forth. Well, the number of critical beds would rise, but not in an exponential manner. So for example, if you plug in R effective of 1.5, you'll get the number of critical beds that you need to be 1,600. So what this tells you is that first, you can prepare. Second, your sensitivity to leakage in this group of population, the low-risk group, is not high. You can contain also leakages by preparing more beds, but it's not an exponential growth in the number of beds. And also you can monitor, you can see what is the rise of critical beds in this population. And if it goes above your expectation, you can clamp down a bit more on the social distancing of the low risk group. But what you can see here, that the bound itself is reasonable. It's not that we need 20,000 critical beds. For Israel, for example, cannot contain with 20,000 critical beds. Whatever Israel will do, they can never prepare 20,000 critical beds, because each critical bed requires also a staff to maintain it and so forth. But 1,100 or 1,200 critical beds is something that is quite reasonable. Second, next slide, please. So what we said here, we took here worst case assumption, where we took that the actual number of infected individuals, of infected people, is only twice the number of people being tested. So we took a worst case. If one does a proper random survey to understand what is the percentage of infected, I believe that one can get much better numbers. And then the number of critical beds would not be 1,200, could be even 600. If it's 4 times the number of positive people, we can cut by half the number, this bound of number of critical beds. But even if we take the worst case, the number 1,200 is quite reasonable and quite manageable to prepare in order to contain the low risk population. Next slide, please. So this is kind of a summary slide, what are the operational steps given this back of the envelope calculation that I showed you, and the insight about this risk-based division of the population into high risk and low risk. So so the first bullet is that leakage of infection, if it's done over the entire population, is very dangerous, because the spread runs away, it's exponential, and we know that then the health system can be overflowed. But when we look at the leakage sensitivity of the low risk group, the leakage sensitivity is low, because we can cap the number of critical beds, and the sensitivity of the number of critical beds to the expansion rate is not exponential. And we can always monitor and clamp a bit more the social distancing in order to make sure that we're still with our effective of 1.4 or 1.5. We can also start, and these are ideas that are being now circulated in Israel, we can also start with releasing the low risk group in stages. First, let's release them with an R effective of 1.2. Much more social distancing, more rules in terms of people gathering together, minimize, say, no more than 10 people gathering together, and so forth. And then after a while, release a bit the social distancing to a 1.3, then releases the social distancing to a 1.4. One can do it in stages. But the point is that the leakage risk here is low. So you have the flexibility to release, to work the low risk group. On the other hand, the leakage for the high risk group is high, because the high risk group is both the high mortality and require a lot of critical beds. The majority of critical beds are in the high risk group. So you have to be very, very careful with the leakage of the high risk group. Okay? So the third bullet is that the leakage of the low risk group does not translate to an overflow of the ICU capacity. This I think is the most important observation. So consequently, what does this entail? Is that we need to focus our limited resources, the testing, the contact tracing technologies, on the high risk group, and also the people who take care of the high risk group, and let the low risk group go back to work under the social distancing rules. Now, with the high risk group, it's not that you need to quarantine them. It depends on the cooperation of the group, because they are at high risk and they know that they are at high risk. They'll be much more cooperative in strict social distancing. So it depends on the society and the cooperation of the society. One needs just to make sure that the people in high risk understand that they need to self-isolate themselves or or maintain very, very strict social distancing, and and all the testing resources should be focused on them, such that to maintain a lack of leakage. And again, this can be monitored. You see the number of critical beds that are occupied by the high-risk group, and if this rises in a non-linear manner, you quickly clamp down more severely on the high-risk group to make sure that you control the spread of the high-risk group. And I think the last point here is that when you look at mortality, mortality needs to be measured over the entire population, not only on a section of society. So when you look at the mortality over the entire population, this method of separating based on risk has the potential of the lowest mortality, because the susceptible group is the high-risk group. They have the high mortality, and you are keeping them safe as much as possible. In the extreme case, you're even quarantining them. You are keeping them safe as much as possible. And then you'll be releasing them once a vaccine has arrived, or you have achieved the herd immunity with the low-risk population, so that the overall mortality of society would be as low as possible, because you are keeping safe that section of society which has the highest mortality. And simultaneously, you allow the economy to continue working. Okay? So what I've shown here is kind of back of the envelope calculation. If you look at the more academic paper, it does this in a much more formal manner, developing the bounds using what is called concentration bounds techniques. These are techniques used from computer science and machine learning. These are techniques, statistical techniques of bounds. But I thought here, for this audience, just to do back of the envelope calculations in order to drive home the point. Then when you're looking at the low risk population, the sensitivity for leakage is not high. One can prepare and contain the outburst, even if there is an exponential spread of the low risk population. Okay, so I'll end here, and I'll be happy to take questions. Okay, I'm giving the floor to the moderator.
Speak. Okay. Professor Shashua, thank you for this very thoughtful presentation. And we are now in the stage of Q&A. So if I'm not mistaken, we have already a number of questions that have been sent through the chat. So let us open the floor now. Rodolfo and Jonathan, please go ahead.
Hello, I have a question for Jonathan here. It relates to the case of South Korea that is reporting some cases where patients who have recovered are becoming positive again. Have you adapted the model for this situation?
Am I being heard? Okay.
Yeah.
So those 91 cases of South Korea, it's not clear whether it was a false negative in the tests, because we know that the PCR tests, they have a high rate of false negative, more than 30% false negative. This is why the normal procedure is to take that test twice. But still, even if you take it twice, you have a 9% of false negative. So it could be that those 91 cases that allegedly have been reinfected were simply people who did not recover. And the test showed a false, that showed that are not positive, but it was a false it was a false negative. This is one conjecture. The other conjecture is that the virus has mutated. But if the virus has mutated to a degree where infected people are now completely not immune, we would have seen much more than 91 cases in South Korea. But in any case, the model that we have here, one can maintain it until you have the vaccine. Because what does it say? It says that you release the low-risk group, but under social distancing guidelines with an R effective of 1.4. Now you can continue with this guideline until a biological vaccine arrives. Because the economy can still work. People simply need to be careful with their social distancing. You don't allow congregations of more than X number of people, let's say 10. You don't allow people to go to big events. That will not hurt the economy too much. And you can continue with this for until the vaccine arrives.
Okay. Any other questions, please?
Hello, I got a question from Doa from the WTO. She's asking what would be the case in the airports and for travel matters.
So it depends. If you have someone who's the idea is that by that time, people who enter into the country will pass a PCR test, and a PCR test by that time the answer should come within a few hours. For example, Israel is preparing to have a complete cycle of testing and quarantining in less than 24 hours. So this means that the testing and the result should be done in few hours. And if negative, people will allow to enter the country. I believe most countries will adopt something like this. And then one has to be careful who enters the country, if it's from the low-risk group or from the high-risk group. Someone from the low-risk group who is now negative in the PCR test should enter the country and obey the social distancing of the country with the mask and social distancing and hygiene. And I believe that if something like this is applied globally, not just in one country, but globally, it could allow borders to reopen.
Thank you. Nama Maidan is asking if this was not the method that Boris Johnson tried to implement in the UK, and what happened if it is, and why was it changed in your opinion?
Well, I think the UK did not apply this method. The UK made some recommendations about people of high age to make sure that they are protected. People did not obey the recommendations because at that time they did not see the danger of this virus, and basically the virus spread over the entire population. When the virus spreads over the entire population, we know that the high-risk group creates an overflow of the health system, and this is what happened. But now, after a month of lockdown, people understand the danger and see the mortality and understand the danger of the disease. Now, applying strict guidelines on how to protect the high-risk population is something that people will adhere to, and also the government can enforce it, which was not done in the UK.
Another question from R.D. Prix. Allowing the virus to spread among the low-risk group will also give the virus opportunity to mutate. Have you considered plugging in the probability of the virus mutating to a new strain that could possibly be more worse? There should be are your thoughts on this?
Okay, so our model is agnostic to mutation, and I'll explain why. But before I explain that, this idea of mutation, there's so many unknowns there. So the idea is that if you are infected, you are immune. The question is, how long are you immune? Are you immune for months? Are you immune for years? Are you immune for life? Nobody really knows. The conjecture is that this virus mutates slower than influenza. But again, it's only a conjecture. Nobody really knows. Now, our model does not assume that the virus will not mutate. Our model says that you release the low-risk population under an R effective of 1.4 and wait until a biological vaccine arrives. It means we are not waiting until herd immunity and then releasing all guidelines. Wait until a vaccine arrives, because going back to social activity and going back to economical activity, to work life under social distancing is possible. It doesn't compromise too much life. You know, you don't hug each other. You make sure you have a mask while you're in public spaces, and you protect the high-risk population. This is something that is feasible to maintain until a vaccine arrives. If, on the other hand, more data arrives that the virus does not mutate so quickly, and if you are infected, you are really immune at least for a period of time until the vaccine arrives, then once herd immunity is achieved, and in our model it's about 120 days, once the herd immunity is achieved, you can start releasing the social distancing guidelines and allow even more social activity to happen, and then gradually also release the guidelines on the high-risk population. But in any case, if such data is not available, continue this method until the biological vaccine arrives.
Thank you. A question from Jing from the Chinese mission. How about the RO is bigger than 1.4? He's heard of research that result that RO could even reach 3 in some cases.
Yes, indeed. So R effective, the RO, the interval is between 1.4 to 3.8. Could reach 3.8. But these numbers are for unconstrained propagation. So people do not maintain social distancing, do not maintain any guideline to slow the spread. We are assuming that there would be guidelines and enforcement of social distancing among the low-risk population. So masks, social distancing of 2 meters, hygiene in public, alcohol gel everywhere you go, and guidelines of hygiene that are much more heightened than in normal situations. And since countries have now experienced the lockdown, they understand those guidelines and simply should continue those guidelines. And therefore, we assume that the R effective can be on the low range of the interval, the 1.4. But the point is that when you do the calculations and there is a leakage, say from 1.4 to 1.5, it doesn't overflow the health system. So in our calculations, this back of the envelope calculations, it will go from 1,200 critical beds to 1,600 critical beds. Okay? So it's not an overflow. And you can also monitor. You can also monitor the number of critical beds being occupied by the low-risk population. And once you see that it rises above your expectation, you can clamp down a bit more on the social distancing. So it gives you ways of control. But really the message is that it's not an exponential growth of the critical beds, and you can monitor it. On the other hand, with a high-risk population, an exponential growth can translate to an overflow of the critical beds.
Thank you. Another question from Doha, from the WTO. Is this virus affected by the weather or the climate? If so, what are the projections for Africa?
Well, all the data that we have right now is that, in South America, coronavirus is as active as any other place. So we assume that that when summer arrives, the problem would not go away.
I have one question. Yeah.
Go ahead.
Yeah, I have one question from here. To the best of my knowledge, the vast majority of the participants in this Zoom meeting are people who are members of different delegations to the UN or to the WTO, or people from the secretariats of UN organizations and the WTO. These are people that normally in their daily life engage in international cooperation, international coordination, international trade, policy making. is there any message or any lesson that you can tell us in terms of what might be a good way to proceed in order to maintain the world as one unit and in order to enhance collaboration in times where it seems that some countries are basically going backwards and trying to solve problems by themselves?
Well, our first intention was to solve the problem for Israel. But we wrote the first paper in English. The reason we wrote it, we have now another paper also in Hebrew, but we wrote it in English because we feel that the problem needs to be addressed at a global level and not just country by country. That means if there is a method that makes sense, and it makes sense on a universal manner, so it's not population based. If it makes sense, we should strive to have it universally adopted, because we're talking about a global economy, a global trade, borders that should be open for passengers. This is how trade is being conducted. It's very, very difficult to do trade through Zoom. This is why it is very, very important to share ideas, share data, which are being done. Data is being shared, but shared ideas and share solutions such that we can find solutions that make sense on a universal scale. Because this thing is going to stay with us for at least a year and a half. And if the economy does not jumpstart back to where it was before the pandemic, we could find ourselves in a crisis bigger than what we have ever known in the past 100 years.
Another question here from Jonathan from the WTO. As you pointed out, this is a global problem, and if it spreads, it's harder to contain. Can you speak about the current situation in places where social distancing is not possible? I'm thinking of places like in India or Brazil. Thank you.
So I think Israel also has pockets, like ultra-Orthodox pockets where people live in very, very compact environments as a way of life. They live like that by choice. So the method that we present here actually works in their favor, because the majority of the population, if you look at India, the majority, the amount of low-risk people, young people, is very, very high. So what this method says is that put your resources on protecting the high-risk group, the people above 65, make sure that they are a bit isolated, social distance, even quarantine them in certain places, in hotel rooms or build places for them for a period of times. It's much easier to apply social distancing on the right segment of the population than apply it universally over the entire population. That cannot work, because people who are low risk, they know that they are low risk. And at some point, they'll start not cooperating. They know that from a health perspective, they are low risk. Yet, on the other hand, their livelihood is being compromised from an economical standpoint. So we should expect seeing social unrest among the low-risk population if we don't focus our energy and resources on the high-risk population. So I think this is even more acute in countries like India and Brazil, in pockets where people live in very compact, in a very high density manner.
Okay, so it seems to me that there are no other questions, no additional questions. So let me say a few words, and I guess that then we will conclude this meeting. So first of all, Professor Shashua, thank you very much for this presentation and for taking the time to brief us about your model and about your discussions with other academic institutions. I think it has been very helpful and gave us a lot of food for thought. I guess no one is revealing a secret when we say that the pandemic has a far-reaching implications on all of us and our daily life in almost any aspect. In terms of trade, which is the main or the core business of the vast majority of the participants in this meeting, I mean, we already see that more and more countries impose new trade restrictions on exports, on imports, and definitely this is something that we will have to tackle in the very near future. If I'm able to make a small observation on my own responsibility, I may say that perhaps in these times of really pressure everywhere, it is really important to stay connected and to maintain the collaboration, because I think that by collaborating, this might be the best way or the most efficient way to face this challenge that we are all facing actually all around the world. So again, thank you for your time. Thank you everyone for joining us. We have recorded the session and we will post it, and Rodolfo will circulate information on where you could see it. So again, thank you everyone for your time. Thank you, Professor Shashua, and I wish all of us good health and good day. Thank you.
Thank you very much.